Documentation. Documentation becomes a permanent part of the client's medical record. It must be accurate, timely, comprehensive, and flexible. It ensures continuity of care, saves time, and minimizes the risk of errors. It can be in electronic format, handwritten, narrative, or flowchart. No one who is directly involved in a patient's care has a right to a patient's medical record. Standards may be slightly different from facility to facility. Current documentation standards require that each client has an assessment. That assessment must include physical, psychosocial, environmental, self-care, client education, knowledge level, and discharge planning needs. Facility reimbursement is often based on the completeness and accuracy of the nurse's documentation. It has to be done right. Communication with the healthcare team is done by the records or the chart. This is a confidential, permanent legal document. It's done through reports, which are oral, written, or audio taped exchange of information. Conferences, where team members communicate in a group. Consultations. A professional caregiver is giving formal advice to another caregiver. And referrals, where an arrangement for services are made by another care provider. These are the reasons for records. We have to keep appropriate, accurate medical records. This is a list of some common documentation errors. Documentation errors can result in malpractice cases, so it is vital that you be complete in your documentation and accurate. If it wasn't documented, it wasn't done. I don't care how many people saw you perform a task. If you did not document it in the patient's medical record, you have no way to prove that it was done. It has to be documented. So, legal guidelines for recording. You cannot erase, use correction fluid, or cover up any documentation errors. Make sure that you keep your documentation factual. Don't use names, only use initials. Do not use pronouns. Document statements and quotes and reference who made that statement. Mark through any extra space and sign your name at the end. Do not document in felt tip pens or pencil. It must be in black ink. You can document that a task was completed by someone else if you document vital signs obtained by ABRN, if applicable, or how that, whatever those initials and credentials would be. Again, documentation should always be concise and factual. Don't make it wordy. Begin each entry with the date and time and end it with your signature and title. If something was done at 10:05 and something else was done at 10:10, do not put all of that in one note. They should be two separate, distinct notes with their own date and time and your signature and title. Never leave a computer screen unattended or patient charts unattended. Make sure that the charts are put away and make sure the screen is not viewable. Computer screen is not viewable by the public. So, guidelines for quality documentation and reporting. Again, it has to be factual. Never use words such as seems or appears because those are not factual. Make sure that you provide objective signs. It must be accurate. Use exact measurements rather than descriptive measurements such as adequate, large, or sufficient. How much is sufficient? Was it 150 mLs? Was it only 25? Use only approved abbreviations, and each facility has their abbreviations that have been approved. Documentation must be complete. Include additional detail when it is pertinent or relevant. It must be current. You have to document as soon as possible after the occurrence. Unfortunately, sometimes that means at shift change. And documentation should be organized. It has to be in a logical order. Different ways of recording include a paper record. These are episode-oriented. A record is kept separate for each hospitalization or office visit. It includes key information, and it can be lost from one episode of care to the other. For example, allergies or medications or treatment complications. Electronic health records. These are a digital version of a patient's medical record. They integrate all of a patient's information in one record. It does improve continuity of care. It usually is quicker, but documentation may not be as complete as it should because people tend to get lazy, so you have to be very careful. Narrative documentation is the traditional method, and that is what you start off learning in nursing school. It is more time-consuming. Problem-oriented medical record. Let me back up. With a narrative, then you have the flow chart. The flow chart has specific areas that you document on. And with the electronic documentation, they have drop-down boxes within that specific area. For example, cardiovascular, heart sounds, S1, S2 heard, murmurs, pulses, palpable, capillary refill, all of that would be listed under cardiovascular. The problem-oriented medical record has a database, a problem list, a care plan, and progress notes. SOAP charting. This just helps separate all of your documentation so you have everything there. You have the subjective, in other words, what the client says, objective, which is what you have observed or assessed, the assessment, and then the plan. SOAPy also adds intervention and evaluation. PI is just the problem, intervention, and evaluation. Focus charting is data, action, and response. Source records, there's a separate section for each discipline. It does not easily show how problems are interrelated or coordinated. Charting by exception means that you only document when something is out of the established normal. Case management plan and critical pathways incorporate a multidisciplinary approach to care. Excuse me. Variances are unexpected outcomes, unmet goals, and interventions that are not mentioned in the pathway. Common record-keeping forms include your admission nursing history form, which will guide the nurse through a complete assessment to identify relevant nursing diagnoses or problems. Flow sheets and graphic records that help team members quickly see patient trends over time and decrease time spent on writing narrative notes. They can be very short or very detailed. A patient care summary or Cardex is a portable flip-over file or a notebook that has patient information that is easily accessed and available. It really does help in use for nursing report from shift to shift. Standardized care plans. They can be pre-printed or they can be available on a computer program. These are established guidelines that are used to care for patients who have similar health problems. Be aware of facility requirements for care plan documentation frequency. Discharge summary forms. Discharge preparation should begin at the time the client is admitted. They may be standardized with an ability to individualize. Ascertain the client's or family's understanding of information always. And acuity records, which are standardized amounts of time that's given for a specific task, and it helps justify or support staffing requirements. In home care documentation, Medicare has specific guidelines for establishing eligibility for home care, and those Medicare guidelines for establishing a patient's home care cost reimbursement serve as the basis for documentation by home care nurses. So again, we get into reimbursement because of our documentation. Long-term health care documentation can be very different. The Omnibus Budget Reconciliation Act of 1987 includes Medicare and Medicaid legislation that guides long-term care documentation. Documentation tips. If a mistake is made in documentation, you cross it out with a single line. The mistake has to remain readable. You sign your initials and your credentials. If you are correcting an error in an electronic chart, then the computer will automatically draw a single line through that with the date and time, and whoever has gone in to make that correction, it puts your name with it. If you forgot to document an entry, then you document in real time, but you put late entry or LE prior to the documentation. Include the date and the time the entry should have been included. If an intervention is done, you always document an evaluation of the intervention response approximately 30 to 60 minutes later. And always document attempts to contact and/or any contact that you've had with the physician regarding client concerns and the physician response. Just an FYI on late entries, these are not recommended, because if you go back in and add a late entry, if an attorney gets a hold of that chart and sees a late entry, they can question as to exactly when that documentation was added. Was it added in at an appropriate time, or did you go back in months later and add an entry? When you receive an order, you include the frequency, route, and specific directions in the order. Include how the order was received. If it was a telephone order, you can abbreviate T period O period or P period O period. With a verbal order, V period O period. A standing order would be S period O period. You include the health care provider's name, and for example, if you received the order from a physician's office, frequently it will be the office nurse who calls in the order, so that would be a third party. So you would include the name of the third party and the credentials, and then your name and your credentials. So for example, you have received a voice order. It would be V period O period Dr. Fixit / I period M period nurse RN / U period R period nurse 2 LPN. The nurse that signs off on any orders that have been recorded in the chart is responsible for the accuracy and the completeness of those orders being taken off. If you sign off or when you sign off on the order sheet, you bracket one side of the order, writing the date and time that you signed off, your name, and your credentials. Usually that's done on the right side of the orders. Some orders will require 2 nurses to sign off on if there is a high risk of complications, if there were any errors that were made. For example, there is a form called a heparin nomogram where calculations must be made to determine appropriate dosages. Those would require 2 nurses' signatures. When you're reporting, you have the handoff report, which will occur with a transfer of patient care, whether it's transfer from unit to unit or transfer from shift to shift. This will provide continuity and individualized care. These reports are usually quick and efficient. They can be verbal, taped, or occur in a client room. Make sure that when you are listening to report that you're taking notes. There's many nurses that develop their own pre-printed forms, or they use someone else's pre-printed forms, or they just take notes. Allow the offgoing nurse to complete the report prior to asking any clarification questions or any questions of information that they may have omitted. If report is taped or other nurses report after you, you may need to provide the oncoming nurse with an update. Telephone reports and orders. Organize your information into the SBAR, or Situation Background Assessment Recommendation. This will help standardize communication and eliminate omission of information. Always document every physician call, and always read back telephone orders. Incident or occurrence reports, or variance reports is another name, are used to document any event that is not consistent with the routine operation of a healthcare unit or the routine care of a patient. Never put in your documentation that you have completed an incident report. Follow agency policy for completion of these reports. Health informatics is the application of computer and information science for managing health-related data. The goal is to enhance the quality and efficiency of care that's provided. Facilities must have electronic health records with meaningful use of data generated from the electronic health record, or I think it's 2015, they will begin to be penalized by the government if they don't have electronic health records in place. Nursing informatics is a nursing specialty. We have Healthcare Information Systems, or HIS, which is a group of systems used in a healthcare organization to support and enhance healthcare. It consists of one or more computerized clinical information systems, administrative information systems. It makes data entry and communication of data and information more efficient. It supports the way that nurses function and work, and supports and enhances nursing practice through improved access to information and clinical decision-making tools. Nursing information systems are computer systems that manage clinical data from a variety of healthcare environments. There are several advantages: increased time to spend with patients, better access to information, reduces errors of omission, enhanced quality of documentation, reduced hospital cost, increased nurse job satisfaction, compliance with accrediting agencies, and common clinical database development. Systems are designed with privacy, confidentiality, and security mechanisms. There are legal risks. Most employees within a facility can access client information, but understand that IT has the ability to track who accesses information, to make sure that the wrong people are not getting into the wrong information. There is a legal risk in the handling and disposal of information. Protection of the confidentiality of patients' health information and security of computer systems are top priorities that include login processes, audit trails, firewalls, data recovery processes, and policies about handling and disposing of data to protect patient information. And finally, clinical information systems. Within the CIS is order entry and computerized provider order entry, or CPOE. These all help to improve accuracy, speed implementation, improve productivity, and save money.